started, Nick. Would you like to go ahead and kick this off?
Yeah. Hi, everyone. My name is Nicholas Franco, and I work in actually the Department of Family Medicine, but I coordinate this group for supporting both physicians and healthcare professionals around learning about and improving long COVID care. If you ever have any questions, please feel free to reach out to me. And I will kick it over to Dr. Chopra. And I will give one last reminder, if you can please fill out the poll. It does help us a lot. So it will be live during the whole presentation. Feel free to fill it out on your own time. Thanks so much.
Thank you. Thank you, Nick. Thank you so much for putting this together. And I really appreciate all your work with the group. So welcome, everyone. I'm Anita Chopra. I am an internist at UW Medicine and one of the lead physicians at the UW Post-COVID Rehab and Recovery Clinic. And I'm so honored to welcome Dr. Payal Patel. Dr. Patel is a neurologist with special qualification in child neurology. She practices at Seattle Children's Hospital. She has a special interest in neuro-infectious disease. So she is the person to reach out to get information about neurological complications of PASC, which is our topic for today. But I want to talk a little bit about Dr. Patel's expertise in this area. She is also a part of the post-COVID rehab and recovery clinic at University of Washington. She is a co-investigator for the AHRQ grant that this clinic has received. She's also principal investigator for the post-acute sequelae of SARS-CoV-2 in pediatric patients. So welcome, Dr. Patel.
Thank you, Dr. Chopra, and thank you for this invitation. It really is great to have a meeting of minds and to kind of share some of the work that we've done together as a clinical work group with other clinicians.
Thank you so much for coming today and giving us time. And I would like to start off by talking about, the wide range of long COVID neurological symptoms ranging from headache to paresthesias, and most commonly presented symptom, which is brain fog, which is like the layperson term for this really sort of collection of symptoms, which include memory changes and processing problems and word recall problems. So what encompasses brain fog? What are some of the typical symptoms that you see, and are there any patterns or clusters of this condition?
Yeah, absolutely. Such an important question because many of our patients will start with this symptom, brain fog, which to me is very similar to like dizziness, right? And then you have to kind of delve into what the patient is actually experiencing to help really understand what the etiology might be. So for brain fog, I try to differentiate between whether or not the challenges are related to fatigue or if the challenges seem to not be related to fatigue. Because there are a group of patients that I found where fatigue is kind of this all-encompassing symptom, both with and without pain, and their ability to function within the episode of the fatigue is impaired, and that is what they're labeling as brain fog. Independently, I've had patients that have trouble with activities of daily living, for example, paying bills, and a lot of the metrics that we use to determine independence, right? From a clinical standpoint, one thing that I found is that older patients who have been hospitalized, patients who have a prolonged hospital or ICU stay, and have other comorbidities often fall into this latter bucket. And it makes me wonder if some of those symptoms are related to the ICU stay itself, right? And post-ICU cognitive changes. For younger patients, and in particular in pediatric patients, they actually don't say brain fog, but they do endorse that it's tough to do their day-to-day activities, to participate in school in their full ability because of the fatigue. And I see this a lot in the younger adult patients that I see here at Madison Clinic, the handful that have been diagnosed with long COVID jointly, is that they're able to function and able to do activities of daily living, but the predominant symptom that is clouding everything is the fatigue. And so I try to separate those two and try to work those two up differently and offer treatments differently in both of those subgroups. I think you're muted.
Sorry. So,
Yeah.
Payal, that's very helpful because we often see people coming in with overlapping symptoms of brain fog and fatigue with worsening brain fog symptoms when they are very tired. So the more tired they are, the worse they feel with, the fogginess and the processing and attention problems. So this is very important to tease out whether it's just an extension of fatigue or are there some cognitive symptoms involved. Can you talk about some of the hypotheses with regards to the cause of the brain fog?
That's a really, really great question, Dr. Chopra. And I wish I had a very clear answer. I, of course, don't at this time. The most recent data that I saw presented by Dr. Avindranath, who is the director of the neuro-infectious disease unit at NIH, suggests that this is an immune-mediated phenomenon, but not a classic autoimmune-mediated phenomenon. His theory that he will test out soon is that it's not the antibodies attacking the actual tissue, but it's antibodies creating other antibodies which mimic antigens. And so this mimic of the antigen is actually creating the inflammatory cascade that is creating this, which is one of the reasons why he feels that immunosuppressive regimens were not successful. So that's kind of the leading experts' theory behind the pathophysiology of the fatigue and brain fog component. I also think that from a ICU standpoint or related to other medical conditions, there can be comorbidities related to vascular disease. So we do see a higher incidence of stroke. One of the theories following COVID, one of the theories is, could you also see a higher incidence of vascular dementia, maybe a less clinically severe phenotype of vascular dementia following COVID, particularly in some of our patients who are older, who have comorbidities and have ICU stays. So that has been in the back of my mind. And one of the things that we're trying to find out with our neuroimaging study, which is looking at vessel wall imaging in long COVID, is whether or not there's a vascular component to this. There's some very interesting research which also supports the pathophysiology of microclots, which has been seen in diabetes as potentially the agent that perpetrates the injury to the vessel walls and perpetrates the ongoing inflammation that is a contributing factor to brain fog and long COVID.
I think this pathophysiology is so fascinating because that can not only form, sort of shed more light on the cause, but also impact the treatment. For example, we have a study now that talks about reduced tryptophan and serotonin levels in long COVID patients. And I think that the role of SSRIs consequent to this new pathophysiology hypotheses is going to impact the care of these patients as well. So this is very, very fascinating. Thank you so much, Payal, for this. how do we make a diagnosis of neurological task or long COVID? And what are the diagnostic tests that we use?
Yeah, this is a very tricky one. And I really appreciate this question because it's been complex for me to practice as well, particularly in pediatric patients. I make the diagnosis of PASC as a diagnosis of exclusion. So I do try to first see if there is another known entity, such as, a post-concussion syndrome, or particularly for our patients with headaches. I do see if they have a history of headaches, if there's a family history of headaches, and the actual characteristics of the headaches too, if they fit a headache syndrome before making a diagnosis of long COVID. Long COVID in the pediatric population, I feel like is unique in that it is in a population that doesn't have any other clinical comorbidities usually. And what we see is a constellation of symptoms, and it's the constellation of symptoms together that really increases, I believe, the positive predictive value of long COVID. So it's a combination of sleep dysfunction, both with and without mental health symptoms, this post-exertional fatigue, and sometimes it can be extreme. It can be kids that say, I got up to take a shower and I have to go lay back down. So it's really this exertional component to it, but it's at different levels. The headaches occur, but only when the constellation of symptoms are at their worst. So kids will say, I didn't get good sleep for days in a row. I tried to do a lot of different activities and felt incredibly fatigued. And then the headaches develop. So they seem to be a bit secondary. And the other thing that goes along with this, usually, but is not necessary for the diagnosis, is autonomic dysfunction. So individuals will also say, I feel very dizzy too. And sometimes it's hard to differentiate between the dizziness and the fatigue because they seem to come together. So I try to use those clinical symptoms and the absence of another known clinical entity to make the diagnosis of PASC. By the time patients get to my clinic, they've been seen by their primary care providers, and they have had a lot of tests to rule out other things too, right? Like vitamin deficiencies, anemia, some of the common conditions that cause fatigue. So I definitely start at a place where I have some of the most common primary causes of fatigue excluded. And then it's the constellation of these symptoms that really kind of clue me in that this could be long COVID. There was an interesting study that my mentee did looking at polysomnograms from our sleep clinic. So these were individuals who had obstructive sleep apnea. They get serial polysomnograms to determine, the success of their treatment. And then the pandemic hit. So incidentally, some of them developed COVID. They had to get tested for COVID because this was an in-person procedure. And so we were able to take out those who got at least a PCR positive COVID test versus those that were pre-pandemic and those during the pandemic that were receiving treatment that had documented negative COVID testing. And this was important because it was early on in the pandemic where we were doing really good with, lockdowns and people were staying home and the risk of transmission was lower. So we did feel strongly that a negative test did reflect actually no history of this disease. And he found that there was a significant decrease in N3 sleep, which is deep sleep. And that kind of clued me in or had a light bulb moment that patients often say, not just that their sleep is poor, but that they'll sleep, but they'll wake up and not feel rested. That's kind of a classic clinical clue, potentially, that we're not dealing with insomnia, we're not dealing with other sleep concerns, but potentially a COVID-related sleep disorder. And one of my theories is that this lack of N3 sleep is what is exacerbating this fatigue, but both are symptoms of some underlying process that we're still trying to figure out.
I think this was so well put because on one hand, patients when they come to us, they have fatigue, ongoing fatigue, and they have the brain fog, and they themselves are not able to distinguish which is which is which. And the symptoms are overlapping and entrenched in such a way and intertwined in such a way that the exacerbation of one leads to aggravation of the other. And it's very important for our primary care physicians, especially who see these patients in their clinics, to know that there is no one good test to diagnose these patients.
Yeah.
And especially by the time they come to us in the long COVID clinic, they have had all different tests and all expensive investigations under the sun.
Right.
And sometimes it may not be needed at all.
Right.
However, we do recommend the initial battery of testing, which amongst which we would check them for their thyroid levels. We would do the routine CBC and Chem7, also check their vitamin D levels. And as you rightly pointed out, sleep study is sometimes the most important factor because a lot of these patients have undiagnosed underlying sleep apnea. Payal, I want to touch upon the most important question I have as a primary care physician. What is your threshold for imaging? When do
Yeah.
we image these patients?
Yeah. And that's a really good question. And I will try to differentiate between the different symptomatology because each symptomatology has its own criteria that would prompt imaging. I will also share a consensus guideline that was developed by a group of adult neurologists that basically goes through every single symptom that we see in long COVID, the history that they take for each of these, and what prompts further evaluation and kind of uh, the fork, I guess, in the road that this is not long COVID, this is something else, right? So for headaches in particular, I really look at the pattern. And this has been really tricky because I have seen an increase in what we call new daily persistent headaches, which are headaches that come out all of a sudden in someone who doesn't have a headache history, and they are every single day chronic headaches. Usually with headache syndromes, as you know from clinical practice, they tend to build over time, right? And they tend to have life triggers and they follow this kind of waxing and waning pattern. And then at some point, there is some life event that triggers chronic headaches, and then it kind of spirals from there. In a lot of our pediatric patients, and this is even outside of my COVID clinic, I have seen patients come in with new daily persistent headache that had no headache history before. That has always prompted imaging for me because that is one of the criteria, right, that we use as red flags for imaging, along with positional features of the headache, along with the location being occipital, any signs of increased pressure, and some of the standard things that we use to differentiate between what headaches should be imaged and what shouldn't. All of them have been reassuringly normal. The RECOVER study, which is this national study, and has multiple arms. So one of the arms that I'm involved in is the electronic healthcare record arm. And we're actually looking at that now, both in pediatrics and adults, is the diagnosis codes of some of these headache syndromes and how they've changed over time to see if we can see, at least through the coding, if there is an increase in incidence of headache syndromes, but also the patterns that we're seeing. Reassuringly, too, that rates and the patterns of these headaches normalize over the course of the first 3 to 6 months, and they go back to an intermittent pattern that we would expect. But this was a very surprising clinical phenomenon that I saw myself, but also our headache providers at Seattle Children's were also endorsing. Then for cognitive change, I would really look at the risk factors of dementia itself. And so family history of dementia, there are cognitive concerns related to post-acute sequelae of COVID-19, but no frank findings of deficits on day-to-day activities outside of the fatigue component. So if you notice someone who has a lot of energy, right, and is able to do from an energy standpoint their daily activities, but struggles, that would be a sign that this is not long COVID and this is potentially something else. I think those are the two big symptoms that I personally worry about misdiagnosing, as long COVID and then kind of prematurely stopping the workup. But I'm open to discussing the thought process for any other symptoms that come up commonly in your practice.
I think it was wonderful what you said about the red flags prompting imaging. Not every patient who comes with a headache or lingering post-COVID symptoms needs imaging, but some of them do. For example, if they have red flags with positional symptoms, or if they have nausea, vomiting, new or worsening headaches, visual symptoms, those would prompt, imaging. But most of the times when patients come to see us in the long COVID clinic, like I said, they have not only had imaging, but also neuropsychiatric testing. So they have gone one step even beyond the imaging. So Payal, I'm now going to switch gears and talk about management. I know that this is a sort of a how should I say, there's nothing substantiated. There's no one good magic treatment for long COVID, especially the neurological symptoms. And I know that we are also using a multidisciplinary approach to these patients. And I think that is the key takeaway point of all these specialties coming together, as we see in our own clinic, different specialties coming together. Can you talk a little bit about the multidisciplinary approach? What all specialties do you see coming together as a team to treat these patients?
Yeah, absolutely. So some of a lot of what I learned and implemented in clinical practice has been because of our group. And so I should say that this is, I have learned from you, Dr. Chopra, Dr. Friedley, our rehab specialists, and then have adapted it to children. In the pediatric realm, we have a few similar resources that the long COVID clinic has at UW. One important one is biofeedback. And so we have adolescent subspecialists that do biofeedback that's similar to cognitive behavioral therapy, but not exactly cognitive behavioral therapy. There's a component of meditation to it. A lot of patients, particularly patients that endorse pain, have benefited tremendously from the biofeedback program. Additionally, we now our physical therapists at Children's know what we're saying when we say a pacing program, right? But it took a few meetings to get that ironed out. But really, our relationship has been growing with physical therapists, pediatric physical therapists in the area too, because of this work. But really, it's targeting that sub-symptom threshold activity. So not no activity, but not full force activity that kids are usually accustomed to. And then gradually increasing the activity week by week, but incredibly gradually. And I kind of joke with my patients and say that your physical therapist is your health coach, right? Like I see you every 3 to 6 months, but your physical therapist is a person that's going to continually monitor your symptoms and make sure that you are not overexerting yourself, but continue to make progress. And that has been a key factor in our care. Early on, when we established our neuro-COVID clinic at Children's, we also had our neuropsych team as part of our multidisciplinary clinic. We found, though, thankfully, that there weren't any cognitive deficits on our evaluations, thankfully, even in kids with very frank neurologic disease, such as acute demyelinating encephalomyelitis that ended up in the ICU, they actually recovered really well. And so after about a year and a half of having them do cognitive testing on all new patients, and then at 6 months and then year intervals, we actually stopped that practice because kids weren't demonstrating overt cognitive deficits and were recovering beautifully. I use that data to support pacing for my pediatric patients. And that's one of the reasons why, going back to our initial discussion, I kind of put people into two buckets. One where the fatigue is kind of the umbrella symptom and it presents as brain fog. And another where fatigue is not a predominant symptom. There are other cognitive concerns going on. These patients actually do have cognitive deficits on exam and on neuropsych testing. So I try to separate those two when I decide how to offer clinical advice. And the management piece really focuses on pacing for children. I think you mentioned, Dr. Chopra, too, SSRIs. So that is definitely an important component of recovery. The way that I talk to kids, at least, is I say that, this is a component of your symptoms, your mental health symptoms. And part of your engagement with the recovery process is, or maybe lack of engagement initially, is due to some of the mental health symptoms. So we treat that concurrently. We address the mental health symptoms with biofeedback, sometimes SSRIs, sometimes the SSRIs, thankfully, are already started by the primary care provider by the time they come see me. And I encourage continued use and encourage them to treat both simultaneously.
This is so very helpful, and I am seeing a lot of wonderful engagement and questions from the audience. So, Payal, let's tackle some of these questions and see if we can help folks. So, the first question is from Emily. I've seen patients with prior occasional migraines who have had much more frequent, though milder in severity, migraine type headaches, along with fatigue post-COVID. Has that been described?
Yeah, that's a good question. That has definitely been diagnosed. That's what we are trying to tease out through the electronic healthcare record review. Seattle Children's is one of 8 pediatric sites, and I think the adult PCOR net is even broader than that. So we are looking at not just incidence of new headaches, but if there is a change in the frequency of seeing providers, of treatment patterns, if they go from abortive treatment that's used intermittently to a preventative treatment, then that's a sign that, their disease has worsened. Clinically, though, I do think that this is a key component. I don't call that long COVID, although I've seen some referrals that have labeled it as long COVID. I do think this is an exacerbation of the underlying disease. And Dr. Friedley puts it wonderfully when she calls COVID lighter fluid. Any disease that you had before when you get COVID is worse after. And we see this across all different subspecialties, and migraine is not immune to this. Yeah.
I think that was a wonderful question, Emily. And Emily's other question is around SSRIs, and She's wondering if you use SSRIs in patients who only have fatigue and no other symptoms of depression.
I don't. I don't. I usually start with pacing. Um, I I don't pull patients off of it if they've already started. And the other thing too that I do if patients come with a headache component is actually I don't use SSRIs, I use amitriptyline or nortriptyline, which are headache preventative medications. And so I try to tackle both or try to tackle all the symptoms under one medication, and especially a medication that I'm familiar with. So there's so many different, I think, decision trees that kind of go through my head. But if fatigue is a primary component and sleep is a primary component, we actually have a sleep hygiene protocol that we roll out that's incredibly strict. And one of the benefits about working with kids is that you have parents that can enforce a lot of these changes, which they do very readily. Um, and then we try the pacing. And then I see them back a little sooner than I see my other patients. And so I see them back actually in about 3 months because I want to make sure that they are following through with the guidance that we're giving. And sometimes it changes the symptoms that are bothering them, and it doesn't come out in that first visit that there is a mental health component to this, but maybe in the second visit, we'll realize that, I prescribe PT, but it's really hard to get to PT, and they don't want to get to PT. They don't want to talk to their friends. And then we kind of go down a different road.
Also, I just want to add to that. I loved what you said about the different decision trees. And a lot of the brain fog, as people call it, is also linked to post-exertional malaise. So the chronic fatigue, post-exertional malaise, and then going on to mood disorders, those lines are very blurred in some of the long COVID patients that we see. So in those cases, sometimes SSRIs are very helpful. We have seen patients where either they were suffering from uh, chronic pain, for example, along with these symptoms and had mood disorders. They were given Cymbalta, duloxetine, and their symptoms improved in general overall improvement. And then we have other patients who had post exertional malaise leading on to depression and anxiety symptoms. And we give them SSRIs in combination with all the other strategies that we use to sort of manage their PEM or post exertional malaise. They do improve. So SSRIs are going to be an exciting sort of class of medication, and their role needs to be fully established in managing long COVID patients. But definitely, it's a very exciting study that we have linking low serotonin levels to PEM in these patients. There's another very good question from Shivani, and she says, I'm a hospitalist. I think it's harder to think of long COVID as a reason for symptoms, as so much going on with patients, especially geriatric patients, coming in with confusion, sometimes with no clear explanation. Do you have any suggestion on how to assess them with respect to long COVID syndrome? So, inpatient, very exciting, very good question.
Yeah, and this is a tough one because I don't see adults inpatient. And it's been a while because the last time I saw adults was outside of the neuro HIV clinic, which is a very different kind of clinical world, was many years ago. So I'll try my best to answer this question. I do think that older patients who end up in the hospital with new onset confusion, but otherwise were doing well as an outpatient without any overt cognitive change would not prompt me to diagnose long COVID. I have my suspicions that a lot of what is diagnosed as long COVID in our older patients are actually something else. Very similar to the fact that we, see an uptick in migraines. I wonder if we are actually seeing an uptick in the processes that underlie dementia, right? But at a subclinical level, and so we are not picking it up on the limited diagnostic tools that we have for dementia, such as MRIs. So I don't have a perfect answer for how, if you saw a patient tomorrow on your hospitalist service who came in with cognitive changes and had COVID like a few weeks ago, how you would know it's not long COVID. I would say I wouldn't treat that patient, or I would do the same diagnostic tests and recommend the same diagnostic tests as I would pre-COVID, and look for alternate causes and use COVID as a diagnosis of exclusion. But I wonder if COVID changes the trajectory of the pathology of a disease process, which means that you may see more, but of an entity that hopefully is already known.
I agree.
That's
I
helpful.
think, yes, no, that's very helpful. And I think that COVID is long COVID or post-acute sequelae of COVID is something that we see on longitudinal, like an ongoing outpatient sort of follow-up. And it may not play a role, a significant role in acute hospital setting where patients are admitted with acute conditions, and it may not alter our decision-making, tree or algorithms that we use. I want to, Payal, talk a little bit about low-dose naltrexone. This is an exciting therapy. Patients have read about it. Patients ask us about it. And this is a medication which is showing exciting, sort of results in patients who are taking it. In our adult patients, we are prescribing it to people who have chronic fatigue symptoms, as well as, especially if they are dealing with arthralgias and chronic pain, and also shows improvement in brain fog. What is your experience with low dose naltrexone? Have you noticed benefit in your patients?
Yeah, so it's not approved for pediatric patients. So I have not used it in my pediatric patients. There are, I think, a few patients that Nikki and I share who have aged into the adult world and now are fully in her clinic and hopefully benefit from low dose naltrexone. I saw, because you sent me the questions graciously early, I did do a literature review. The data is promising. I think that, so one thing to consider with all of the clinical cohort studies is that they do have comparison groups, but I wonder if the clinical characteristics of the comparison groups are different, right? And for example, those individuals who are prescribed low-dose naltrexone have more of a pain phenotype. And that leads to maybe even subconsciously early initiation of low-dose naltrexone in the decision tree, and then improvement in their symptoms because they all seem to be linked, right? One gets better and then another gets better. There's also some really good data looking at quality of life, which does make sense too clinically, that if you treat the pain, that you improve the quality of life and overall people feel better. I do think there are many randomized control trials that are currently underway across the world. And so I think we'll have this answer very shortly. There are studies that have tried to mimic randomized control trials, right? So they'll say, this was half of our patients incidentally ended up on low-dose naltrexone because of provider preferences and half did not. But I still don't feel like that is adequate to answer how much of a benefit low-dose naltrexone will give you. I think there's no doubt that it is beneficial, particularly in the pain phenotype group. But what is the benefit compared to our current standard of care? And is this generalizable across all patients? I think remains to be seen.
Yeah,
I'd be
I agree.
interested in hearing your thoughts, Dr. Chopra, because
I think that you are so right. I think that there is, though this medication is very promising and lower doses from ranging from 1 to 4.5 milligram, some things to remember are it's a compounded medication. Sometimes it can be expensive for patients. At other times, the availability becomes a problem. Tolerance to the medication also is another important consideration because it can cause nausea and vomiting. So some patients will also experience that. There are, like you said, trials going on out of Canada that we are awaiting results of. Um, However, clinically, our most of our patients, barring the ones who do have side effects, they are showing improvement. And I agree with you about the prominent arthralgia symptoms or joint pain symptoms that are improving, which is indirectly causing improvement in PEM and brain fog as well. So this is a promising medication for our patients. Payal, I want to also get your thoughts on paresthesias, because a very, very common symptom that I am seeing in adult patients is tingling sensation, uh, other abnormal sensations or feelings in the limbs. A lot of times, my patients will come in and say that they have generalized all over electric shock like sensations, which only started after they had COVID. So this is a very distressing and symptom. And we start off by checking their vitamin B12 levels. In adults, we will often give them gabapentin. But what has been your experience with that, and how difficult is this particular symptom to manage?
yeah. So thankfully I haven't seen that in our pediatric patients. I do see this in my HIV patients actually. And now that you bring it up, because I have those two distinct clinical subgroups, right? I have actually attributed it to HIV, but I'm wondering now if some might be related to COVID itself. I always start with gabapentin only because it is always approved by insurance. And I have learned over time that if I try to jump to another medication, it doesn't get approved. And then I have to backtrack. And I give my patients clear guidance and I say, these are the side effects that most people experience. Gabapentin is only effective with TID dosing, which is pretty challenging to actually do on a day-to-day basis. Sometimes gabapentin usually only works at very high doses, right? And so there have been patients where gabapentin has actually been successful. And then sometimes I fiddle around with the actual dose at each interval to manage side effects and improve quality of life in the interim period. For example, increasing the evening dose so the overall dose is good, and taking the evening dose a little bit early so that it kicks in by the time the patients need to sleep, because that's been a big burden, is trying to fall asleep when they're having these symptoms. I quickly, though, if gabapentin fails, document it and then switch to pregabalin very, very fast. I find for some reason gabapentin is better tolerated, and I think I can increase the dose much more rapidly than I can with gabapentin. It's also BID dosing and has an extended release formulation, has the same mechanism of action, and people have really had improvement in their symptoms with pregabalin. I have also tried, in some instances, duloxetine, And then in rare instances, nortriptyline, but the nortriptyline component I really reserve for individuals that have more of a length-dependent sensory neuropathy, which is more predominantly seen in HIV. And those for whom gabapentin is they have a very strong side effects to gabapentin that makes me reconsider whether or not a trial of pregabalin is useful. I also warn patients that it takes a lot of time to work. We won't see the benefits for months. So not to be discouraged if they take it every day for a few weeks and things are not getting better. I also warn patients that even though what we may see is improvement in the symptoms, but not complete resolution. And that kind of setting themselves up for the expectation that this might be a part of their life in the long term, and that is going to take a while to see the benefits of the medication, I think really helps set expectations. So patients aren't, messaging me in 2 weeks and saying the medication didn't work, so give me a new one. So I think that's been helpful in managing some of potentially these peripheral neuropathies that are related to infections.
So I will just add from the adult perspective that checking vitamin B12 levels and thyroid levels is important in these patients as well. Making sure they are not anemic. That's also we do that in the clinic. Other modalities that we use, which may be non-pharmaceutical, is one is acupuncture. Sometimes that is very helpful to people. The other is general uh, focus on reducing neuroinflammation and using anti-inflammatory diet. I often tell patients about plant-based diet where we are trying to limit or cut down dairy and gluten. Sometimes that is very helpful. It does change people's their entire lifestyle around. But the anti-inflammatory diet has shown to be beneficial in patients with chronic pain and having neurological symptoms. Other modalities which are non-pharmaceutical and we are borrowing from integrative medicine are strategies like using turmeric, CoQ10. Those are some helpful strategies in managing, especially the neurological symptoms of long COVID. So I think these are some different modalities to consider in managing these patients. Payal, we have another question from Amandeep in the chat. Are there any newer headache therapies? I think they're trying to find out if there are any focused long COVID headache therapies.
Yeah, so not focused in long COVID specifically, but I have seen a lot of benefit to the devices. So Cephally is one that is widely available, and my patients, both those that have exacerbation after COVID and those that have new onset, chronic migraines and doesn't seem to have any temporal relation to COVID, have greatly benefited from Cephally. And then they also have an arm device too with that. I'm blanking on the name right now. It's like, it starts with an N. An arm device that attaches to your phone and you can control it via your phone. A lot of the junior patients and the kids really seem to prefer that because they can wear it in class. Could probably wear it to work and no one would ever know. I'll find the name and send it out to the group so that you can share. The other thing too that I like about Cephally is that they actually have a money back guarantee in 90 days. And so you can have patients, if they pay out of pocket, they can always return it if it doesn't work. And I feel like that's a strength um, for for that device. But people seem to really like it. So.
I think Cephali is something that we use in our adult patients a lot as well. And just to remind folks, this is a device that attaches to the forehead. It is helpful in chronic, uh, uh, persistent headaches, like chronic daily headaches, especially patients experiencing more than 15 headaches a month. The way it acts is that it acts on it modulates neurons. Am I right, Payal? Is
Yeah.
that, am I
Yeah.
making so?
No,
And
you're absolutely right. We that's what we think is happening, is that it's modulating how the excitability of the neurons, and yeah.
and then we advise patients to put it on for 20 minutes a day, at the minimum, and they see a reduction in frequency and severity of headaches. So I think Cephali is a very good management option. And then in adults, another exciting medication option is memantine for chronic headaches that we use and as a chronic daily suppression. And surprisingly, this is a medication, of course, that we know of as used in dementia, but it is also used in chronic daily prophylaxis for headaches. So that brings us to the hour and to the end of our session today. Payal, thank you so much for giving us time and such valuable information. And at this time, I'll wait for any questions, any last minute questions that we have in the chat. Otherwise, Nick, over to you to please close the session for us.
Great. Thank you, everyone. So I'll give one last reminder. If you haven't already, please fill out the poll. It should only take a minute or two. It's just a couple questions. You can find it at the kind of dashboard at the bottom there. And thank you to all of you who did fill it out. With that, I think we'll go ahead and look forward to next time. I'll be sending out a newsletter that will include some of the information talked about today summarized and some of those other resources. And we look forward to seeing you at the next one.
Thank you. This
So
was
much, Payal.
wonderful. Yeah, I learned a lot from our back and forth discussion. So I will be trying memantine for some of my 18-year-old patients.